Good morning. I am a reproductive endocrinologist practicing in the Washington, D.C. area in a large IVF clinic. I would like to address the dilemma facing reproductive endocrinologists when it comes to reproductive immunology. I hope to clarify the misconception that reproductive immunology is not a clinically relevant option in the treatment armamentarium for infertility patients. The key question for the clinician to answer is, does immunotherapy for treatment of reproductive failure enhance live births? As the late Dr. Coulomb published, the answer to the question, does immunotherapy for treatment of reproductive failure enhance live births, is no, unless there is an immunologic cause of the reproductive failure. We all accept that pregnancy is a unique state. It is a condition in which two genetically different individuals can coexist. Implantation is a complex process controlled by hormonal, anatomic, and immunologic factors. The fetus, although semi-allogenic, is in an immune-privileged state and is usually not rejected by the maternal system, which keeps a balance between permitting and restricting trophoblast invasion. What is the immunological basis of allorecognition? Sir Peter Medawar first asked this question in 1953. Why is the fetus not rejected? The implanting blastocyst is surrounded by trophectoderm. This differentiates into the villus placenta and the extravillus trophoblastic cells that tap into the maternal blood supply. The extravillus trophoblast comes into direct contact with the immune cells in the decidua and the myometrium. We know the decidua plays an integral role in ensuring immune tolerance towards a semi-allogenic fetoplacental unit and protects the conceptus from the mother's immune system. These physiological mechanisms are mediated by the immune cells, particularly the uterine natural killer cells and the regulatory T cells, which increase in the first trimester. The immune system, we know, plays an important role in the establishment and maintenance of pregnancy. The maternal immune system recognizes the antigens from the semi-allogenic embryo, and the crosstalk between the maternal-fetal interface is one of complex immunomodulation, not maternal ignorance or tolerance. The immune system dysfunction has been associated with several conditions in reproductive medicine. These include endometriosis, infertility, recurrent pregnancy loss, recurrent implantation failure, preeclampsia, and preterm delivery. Reproductive failure is in two parts. It is consistent with two manifestations: recurrent pregnancy loss and recurrent implantation failure. It is a severe problem in reproductive medicine. Patients become discouraged, distressed, and despondent with this outcome, and clinicians taking care of these women are frustrated by the lack of success. However, international guidelines do not take into account immunological factors, and the clinical dilemma arises from the fact that international guidelines do not recommend any immunomodulatory treatments. Let me review the different guidelines here. The consensus of these bodies is that there are no randomized controlled trials available which can support the evidence-based medicine that we should practice in this field. The ASRM Practice Committee guidelines published in 2018 stated that in the absence of well-designed, adequately powered randomized controlled trials, patients must be informed of uncertain benefits and risks associated with immunotherapy. There is no evidence to suggest screening for these conditions in an asymptomatic population. Furthermore, it added, immunotherapies reviewed in the present document are either not associated with improved live birth outcome in IVF or have been insufficiently studied to make definitive conclusions regarding benefits and risks. The European Society of Human Reproduction and Embryology has updated guidelines in 2022 that asks two key questions. What is the value of immunological screening in the diagnosis of recurrent pregnancy loss, and which therapeutic interventions should be offered to couples with suspicion of immunological background to increase live birth rate? They found that there is insufficient documentation for the impact of natural killer cells and cytokine abnormalities in the blood or endometrium in patients with recurrent pregnancy loss. It is therefore questionable to select patients for specific treatments due to the presence or absence of immune biomarkers. and unfortunately there are few high-quality controlled trials that have been undertaken in women with recurrent loss, selected due to the presence of immune biomarkers. The Human Fertilization and Embryology Authority in the UK has a traffic light system that they use to give a quick indication of whether the add-on is supported by good quality evidence. At this time, the traffic light ratings are on 11 treatment add-ons. These add-ons are listed here with the traffic light rating. However, the ones I have highlighted in red are the ones I want to address. Assisted hatching, elective freeze-all for blastocysts, endometrial scratching, physiological intracytoplasmic sperm injection, pre-implantation genetic testing for aneuploidy, time-lapse incubation and imaging. These techniques, although they have red lights, are used every day in IVF clinics all around the country. The traffic light system that they have is divided into red, amber, and green. The red light indicates that there is no evidence to show that it is effective and safe. These include the ones that I previously mentioned, and in addition, as you can see highlighted here in red, is reproductive immunology tests and treatment. Therefore, the use of immunological tests and treatments as part of fertility treatment in healthy patients is rated red. This is because there is no evidence from randomized controlled trials to show that they are effective at improving the chances of having a baby for most fertility patients. How do we define recurrent pregnancy loss? In 1983, in a paper published by Zakour and Rock, was the first clinical definition, and it was defined as 3 or more consecutive early pregnancy losses prior to 20 weeks. About 1 to 5% of couples experience recurrent pregnancy loss, and idiopathic cases account for about 50% of recurrent pregnancy loss. However, as you can see here, there are differing definitions from differing guidelines. In 2019, Youssef et al. Published a comparison of the elements of 3 different international guidelines. These are the guidelines from ESHRE, the European Society, the ASRM, which is the American Society, and RCOG, which is the Royal College of OBGYN. As you can see, there's not even agreement as to which gestational age should be included. The 2017 guidelines from ESHRE talks about a positive pregnancy test, whether in the blood or the urine, a gestation of up to 24 weeks, and up to 2 miscarriages consecutive or not. The ASRM in 2013 published guidelines saying the clinical pregnancy has to be documented by a sonogram or a pathological exam of products of conception, and only losses up to 10 weeks can be counted for 2 pregnancy losses which have to be consecutive. The Royal College said all pregnancy losses, and they don't define it any further, but up to 24 weeks and up to 3 miscarriages that have to be consecutive. The ASRM published in 2012 a practice committee document that says approximately 60% of sporadic losses are associated with chromosomal anomalies that are age-related. Yet, the risk of aneuploidy at each age is lower in women with recurrent pregnancy loss than those that undergo sporadic losses. They also concluded that studies of HLA typing, other factors like cytokines, etc., have not been able to be reproduced other than in one laboratory. The proposed immunomodulatory treatments for recurrent loss in the setting of one or more of these findings have not proven effective, and several trials and meta-analyses concluded that IVIG is ineffective for primary recurrent pregnancy loss, and this treatment is not. In this review published in 2021, the authors summarized the different guidelines from ESHRE, ASRM, the German, Austrian, and Swiss societies, and the Royal College. They looked at the testing for anticardiolipin antibodies and antiphospholipid syndrome. As you can see here, the European colleges tested for anti-beta-2 glycoprotein, anticardiolipin antibody, lupus anticoagulant, and on occasions repeated after 12 weeks. ESHRE, ASRM, and the Royal College have different guidelines for testing. As you can see here, with anti-nuclear antibodies, there's a difference in the different colleges' testing. At the ASRM, it could be used for explanatory purposes as at ESHRE. With thyroid antibodies, ASRM does not recommend testing the patient if the patient is euthyroid. We can see here that in the immunological diagnostics mentioned in different guidelines, as far as the alloimmune risk factors are concerned, there is no evidence that there is similarity of thought. At the ASRM and at the Royal College, these are not recommended. At the European colleges, they are only recommended if there's a previous history of an autoimmune disorder. This Cochrane review was published in 2014, and the objective of this review was to assess the effects of any immunotherapy, including paternal leukocyte immunization and intravenous immunoglobulin, on the live birth rate in women with previous unexplained recurrent miscarriage. The various forms of immunotherapy did not show any significant differences between the treatment and the control groups in terms of subsequent live births. They concluded that the review of trials found that none of these treatments provided a significant beneficial effect over placebo in improving the live birth rate or lowered the risk of future miscarriage in women who have recurrent miscarriages. Moving on to recurrent implantation failure, it is the same story. There is no agreed upon definition, and one review actually had 76 different definitions, and no medical society agrees on a definition or evaluation. But we do know that the recurrent implantation failure represents the next frontier in reproductive medicine. IVF success rates have improved over the last decade, especially in older women. Multiple failed cycles, however, can cause frustration and leave patients desperate for answers. Success rates remain stable, and about 10% of women using ART still do not achieve a pregnancy. But a new challenge has emerged, that of recurrent implantation failure. This is the story of IVF since its first babies born in 1978. The technological advances that have occurred over the years, since 1978 when the first IVF baby was born. In 1983, the first donated embryo pregnancy was achieved. In 1984, the first baby produced from a frozen embryo was delivered. In 1986, the first human birth from a frozen egg was delivered. And in 1990, there were several established pregnancies after pre-implantation testing of embryos. And in 1992, the first baby was born from intracytoplasmic sperm injection. What is the chance of a live birth with an intended egg retrieval? The Society of Assisted Reproductive Technology publishes these statistics from all clinics nationwide. This is the preliminary data by age, as you can see here. This data is from the patient's own eggs in SART 2020. It is preliminary data. And if you can see here that under the age of 35, the highest probability of pregnancy of a live birth is about 44.6%, and then decreases over the advanced age of the mother. In this slide, you can see here that with the first embryo transfer, the live birth rate was 36.9% in patients under the age of 35, and down to 2.8% in patients who were over 42. For second and subsequent transfers, the live birth rate went up to 47.6% in patients below the age of 35, and as high as 32% in patients over the age of 42. The most important number, however, is the implantation rate. As you can see here, patients who were below the age of 35 had the highest implantation rate, and that was 52.4%. At the age of 42, the implantation rate was 8.3%, and this is to be expected. On the next slide, we can see that recurrent implantation failure has no consensus in definition, and there's a failure to achieve pregnancy after multiple embryo transfers. The Consortium for PGD at ESHRA has defined recurrent implantation failure as greater than 3 failed embryo transfers with high-quality embryos, although the definition of high-quality embryos is an open question, or the failed transfer of 10 embryos in multiple transfers. The ASRM also defines the failure after 3 good quality embryos. Today we do pre-implantation genetic testing to determine the quality of the embryos. However, good quality is an open question. The other definitions include maternal age, the number of embryos transferred, and the number of cycles completed. In this paper published in 2021 by Atta et al., they calculated a mathematical probability of a 95% chance of implantation and decided that the recurrent implantation failure should be a functional term. It should be caused by factors other than embryo aneuploidy. And in a woman less than 35 years of age, the 95% probability of implantation occurs after 7 untested embryos are transferred. At the age of 38, 10 untested embryos were needed, and at the age of 42, there was no practical number allowed that 95% implantation. In this paper published in January 2021, Pertia et al. Looked at a retrospective review, and they calculated the rate of true recurrent implantation failure is low. They analyzed 4,429 patients who underwent a single embryo transfer of a pre-implantation tested embryo. After the first transfer, 571 of 1,335 patients dropped out. After the second transfer, 176 of 307 patients dropped out. This is real life. Patients get frustrated and emotionally and financially drained and drop out of IVF clinics all the time. They calculated that the cumulative live birth rate after 3 consecutive transfers was 92%. And they concluded that for these patients transferring PGTA tested normal embryos, less than 5% would fail to achieve a live birth. However, if you add the patients who did not have a successful implantation, 56, plus the ones who dropped out in the first round, 571, plus the ones that dropped out in the second round, 176, the total is actually 18% of patients who did not have a successful implantation. What are the maternal causes of implantation failure? They can be divided between genetic, anatomical, endocrine disorders, infection, altered endometrial receptivity, thrombophilia issues, and immunological factors. Other causes of implantation failure range from the embryonic status to male factor to even the IVF protocols that are used in clinics to stimulate egg development. So the recommendation for the clinician then is to consider all these factors: the female partner's age, the number and details of previous miscarriages, other factors including karyotyping of the fetus, and autoimmune disorders. In our clinic, we have a very detailed, intense evaluation of partners. For the female partner, we order a karyotype, thyroid function testing, glucose and insulin, thrombophilia panel, cervical cultures for infection, evaluation of the uterine cavity by either a hysterosalpingogram, a sonohysterogram, or a hysteroscopy, a Doppler sonogram to measure the blood flow of the uterus, and endometrial biopsy to determine not only the window of implantation, but also to rule out factors such as endometritis. Evaluation of the male partner includes a karyotype, a semen analysis, and a DNA fragmentation assay to evaluate the DNA integrity of the sperm. However, per the guidelines, the recommended clinical evaluation only includes parental genetic disorders, uterine malformations, endocrine dysfunction, homeostatic disorders, and for immunological disorders, recurrent pregnancy loss patients are only screened for antiphospholipid antibodies. This is a true case presentation of a patient that was presented to a group of reproductive endocrinologists. This is a 35-year-old female who had 5 PGT tested normal embryos. Transfer number 1 of a single embryo transfer, there was no pregnancy. Transfer number 2, a single embryo transfer, no pregnancy. An endometrial biopsy was performed for the endometrial receptivity assay to determine the window of implantation. That showed a window of 155 hours, which translated to 6.45 days. The prior transfers had been performed at 115 hours, which translated to 4.79 days. Subsequently, the window of implantation was corrected and transfer number 3 was performed with the double embryo transfer. There was a late implantation and a beta HCG on day 7 was positive at 5.4. This was a biochemical pregnancy. Following this, another endometrial biopsy was performed to do a receptiva test for 2 markers, the BCL6, which is synonymous with endometriosis, and CD187, which is significant for endometritis. Following this, a transfer number 4 was performed of her last remaining embryo. This single embryo transfer also resulted in no pregnancy. Doing the same thing over and over again and expecting a different result Well, you all know what that is. The solutions proposed by the group of endocrinologists included the intrauterine infusion of platelet-rich plasma, EMMA and ALICE. These are endometrial biopsy markers for the microbiome. EMMA is the acronym for endometrial microbiome metagenomic analysis, which is a screening test to evaluate the endometrium at the microbiological level. And ALICE is the analysis of infectious chronic endometritis. A hysteroscopy, an intrauterine neupogen infusion, or change in stimulation protocols for the frozen embryo transfer cycle, going from a natural cycle transfer to a modified natural cycle with an HCG trigger and also a GnRH agonist in the form of Lupron suppression. Basically, it's throwing the kitchen sink and hoping something is going to come out. What is evidence-based medicine? It obviously is finding the evidence and using that to make clinical decisions. It is a combination of scientific evidence, clinical experience, and the patient's desires. Although randomized controlled trials are the highest level of evidence, they may not be appropriate when looking at the prognosis question. That question is, what will happen if we do nothing at all? The absence of high-level evidence has prevented immunological factors from being a part of the guideline recommendations, as in enrolling patients in double-blinded, randomized studies where one group is in the placebo arm. Which patient suffering from recurrent implantation failure is going to volunteer for this? Furthermore, lower-level evidence cannot be degraded if the results are consistent when deciding on recommendations. There is a certain amount of patient autonomy also included in these decisions. Patient autonomy is the right of a patient to make a decision about their medical care without their healthcare provider trying to influence the decision. Patient autonomy does allow for healthcare providers to educate the patient, but does not allow the healthcare provider to make the decision for the patient. So today, the challenges facing the clinician practicing reproductive endocrinology is this. How do we diagnose recurrent implantation failure? How do we research the disease for which there is no universal definition? How do we study its prevalence? How do we compare the literature across different patient populations? How do we devise interventions to treat these patients? There are several ongoing randomized controlled trials looking at treatment protocols. The consensus process needed to draw up the guidelines may not include newer information. Multiple failed cycles and the health burden created leads clinicians towards treatment rather than enrolling their patients in randomized controlled trials. At this point in time, the clinician has to have the courage to use their own reason.